Got it. Okay, well, good afternoon and welcome to the Supporting Client Health and Wellness class presented by the Far Northern Regional Center's clinical team. My name is Jen Badger. I'm an RN and I work for FNRC in the Reading office. Our medical director, Dr. Christine Austin, and our staff psychologist, Dr. Bob Boyle, are unavailable today, or I would ask them to introduce themselves. But I can introduce our RN in the Chico office, Nellie Camarena.
Hi, welcome everyone.
Hey, Nellie. So it's so nice to have you all here today, and I think you'll find this information useful in the day-to-day care of our regional center clients. Our classes cover a variety of health-related topics that were identified by regional center providers in a recent survey, as well as health problems commonly faced by individuals with developmental and intellectual disabilities. The first several classes are focusing on psychiatric illnesses and psychotropic medications. And our first class, which was done back in July, was Dr. Boyle's presentation on several psychiatric conditions, for which today, let me see, there we go. Today, I'm going to talk about psychiatric and behavior management medications, but only a few groups of those that specifically are used for the treatment of those conditions that Dr. Boyle talked about last month. Next month, he's going to talk about the other half of the psychiatric conditions that we want to cover. And then in October, I will be covering medications related to those. So this is kind of a four-part series on psychiatric illnesses. Okay. So psychiatric medications are prescribed to control challenging behaviors and psychiatric symptoms. And examples of these are listed here. You've probably worked with people in the past who had some of these challenging behaviors, such as hyperactivity or self-injury, aggression. But please keep in mind as well that challenging behaviors and behavior in itself is part of a mental status exam that's used to assess people who have psychiatric disorders too. So just because someone's having a behavior doesn't necessarily mean it's not related to a psychiatric illness. Behavior is just one part of the symptoms that people can have from psychiatric disorders. However, psychiatric symptoms are more specific in that they include disordered thinking or hallucinations, depression, mania, mood swings, and anxiety. And I'm sure there's others as well, but those are the main ones. So psychotropic medications are drugs or other substances that affect how the brain works, and they cause changes in a person's mood, their level of awareness, their thoughts, and how they're thinking and putting thoughts together, how they feel, or their behaviors. Synonyms for psychotropic are psychoactive or consciousness altering or mind altering medications. And they affect how the brain works. Primarily, the way these medications affect brain function is by changing the way neurotransmitters and chemical messengers in the brain are sent and received between the brain cells or neurons. So I'm going to quickly go over how neurons and neurotransmitters work to help you understand what I'm referring to as we talk about psychotropic medications. Neurons serve as interconnected information processors that are essential for all of the tasks of the nervous system. Like all cells, neurons consist of several different parts, each one serving a specialized function. The nucleus of the neuron is located in the soma, or the main cell body. I don't know if you can see my arrow, but that's this part here. And this is the nucleus or brain of the neuron, if you will. The soma has branching extensions known as dendrites. The neuron is a small information processor, and dendrites serve as input sites where signals are received from other neurons. These signals are transmitted electrically across the soma and down the axon, that's that long tail, and ends with what's called terminal buttons, on kind of like dendrites on that end, right? The terminal buttons, however, are really important for messages being transmitted from one neuron to another. They contain synaptic vesicles, those little bubbles, that house neurotransmitters. And these are the chemical messengers of the nervous system. The neuronal signal moves rapidly down the axon to the terminal buttons, where synaptic vesicles release neurotransmitters into the synapse. The synapse is a very small space between two neurons and is an important site where communication between neurons occurs. Once neurotransmitters are released into the synapse, they travel across the small space and bind with corresponding receptors on the dendrite of an adjacent neuron. Receptors, or proteins on the cell surface where neurotransmitters attach, vary in shape, with different shapes matching different neurotransmitters. And the process repeats itself in the new neuron, so messages are sent from neuron to neuron to neuron throughout the brain. Once the signal is delivered, excess neurotransmitters in the synapse that maybe didn't have a spot to connect to the next neuron, those drift away or are broken down into inactive fragments, or they're reabsorbed into the first neuron in a process known as reuptake. Reuptake involves the neurotransmitter being pumped back into the neuron that released it in order to clear the synapse. Clearing that synapse serves both to provide a clear on and off state between signals and to regulate the production of that neurotransmitter. If the synaptic vesicles are full, then that signals that no additional neurotransmitters need to be produced. So if a neurotransmitter is being reabsorbed through reuptake, the production of that neurotransmitter is shut down, meaning there will be less of that neurotransmitter available. And this is really important when talking about psychiatric illnesses. There are several different types of neurotransmitters released by different neurons. Psychological disorders like depression and schizophrenia are associated with imbalances in one or more neurotransmitter systems. Psychotropic medications can help improve the symptoms associated with these disorders by restoring neurotransmitter balance. Some psychoactive drugs can mimic a neurotransmitter at the receptor site and thus strengthen its effects, as if there's more of that neurotransmitter present. Or others can block or impede the normal activity of a neurotransmitter at the receptor. For example, certain symptoms of schizophrenia are associated with overactive dopamine neurotransmission. The antipsychotics used to treat these symptoms block dopamine's effects by binding to its receptors without activating them. Thus, they prevent dopamine released by one neuron from signaling information to adjacent neurons. Reuptake inhibitors prevent unused neurotransmitters from being transported back to the neuron that released them. This leaves more neurotransmitters in the synapse for a longer time, increasing its effects. For example, depression, which has been consistently linked with reduced serotonin levels, is commonly treated with selective serotonin reuptake inhibitors, or SSRIs. By preventing reuptake, SSRIs strengthen the effect of serotonin, giving it more time to interact with serotonin receptors on dendrites. So that's a very quick biology lesson, and hopefully it gives you more understanding as we talk about psychiatric medications on what they're doing on a cellular level. So let's go ahead and move on to talk about medications. Psychotropic medications are divided into these 6 main classes: antipsychotics, antidepressants, mood stabilizers, anti-anxiety, sometimes called anxiolytics, sedatives or hypnotics, and stimulants. So today we're going to cover the top 3. We're going to talk about antipsychotics, antidepressants, and mood stabilizers. Antipsychotics, also known as neuroleptics, are a class of psychotropic medication primarily used to manage psychosis, principally in schizophrenia, but also in a range of other psychotic disorders. They are also the mainstay, together with mood stabilizers, in the treatment of bipolar disorder. First-generation antipsychotics are dopamine receptor antagonists and are known as typical antipsychotics. Second-generation antipsychotics are serotonin and dopamine antagonists and are also known as atypical antipsychotics. Antipsychotic drugs don't cure psychosis, but they can help reduce and control many psychotic symptoms, including delusions and hallucinations, paranoia and hearing voices, anxiety and serious agitation, for example, from feeling threatened, incoherent speech, and muddled thinking. So here is a list of, I think, most of the antipsychotics that are out there. The first generation being the older antipsychotics, and the second generation being newer antipsychotics. And typically the newer second generation antipsychotics carry fewer side effects. Antipsychotic medications can often relieve psychotic symptoms within a matter of days, but sometimes it can take a month or more to return a person to baseline. There's nothing quite as impressive as seeing someone who's floridly psychotic, unable to function, and in crisis, come back to thinking, behaving, and communicating normally with treatment. It's proof that neurotransmitters affected were really out of balance and that the medication works. So let's talk about side effects. The unfortunate aspect of antipsychotic treatment is that these medications do have side effects. While most side effects improve on their own within a few weeks of taking the medication, some do not. Antipsychotics, especially first generation, are anticholinergic. This means they block the action of acetylcholine, a neurotransmitter that affects certain bodily functions. Because of this, antipsychotics can cause dry mouth, constipation, urinary retention, and heat intolerance, in part due to not sweating. Other side effects can be weight gain, akathisia, which is not being able to hold still, sedation or somnolence, dizziness, orthostatic hypotension, which increases the risk of falling, and hormonal imbalances that can lead to amenorrhea, impotence, galactorrhea, and breast enlargement. While some of these effects are minor and can be tolerated when the benefits outweigh the drawbacks, some can be severe enough to require a change in dose or switching to another medication. It's very important that if staff are accompanying a client to see their doctor, that they are familiar with the client enough to be able to report on these types of symptoms if they've been occurring, especially if after a medication adjustment or starting a new med. Having a symptoms tracking sheet can be really helpful in relaying this to the doctor as well. So antipsychotics can also lead to adverse effects, which should be reported to the prescriber right away. These include extrapyramidal side effects or Parkinsonism or tremors, tardive dyskinesia, which is involuntary muscle movements, oftentimes of the mouth or face. They can lower the seizure threshold, meaning that the individual might more easily have seizures. They can cause arrhythmias. Some of them can cause blood abnormalities, particularly if concern is clozapine or clozaril. Metabolic syndrome can occur, which is like rapid weight gain and high blood sugars. The last two on here, these require immediate medical attention. One is the oculogyric crisis. So this is like usually seen in someone who's just started a brand new medication, where the eyes are rolling back and they have severe arching of the neck and back. They can't stop looking upward. And that's an emergency that needs to be treated right away, as well as neuroleptic malignant syndrome, which is really rare, but it can be fatal. And that's recognized by a very high fever, like 102 to 104, rapid heart rate, rigid muscles, and an altered level of consciousness. So, you know, being really out of it and or unresponsive. So those two in particular, when somebody starts a new psychiatric medication or antipsychotic medication, you want to definitely make sure that you're aware of what that is and that you're seeking medical treatment right away if that occurs. So let's go ahead and talk about antidepressants. Certain brain chemicals called neurotransmitters are associated with depression, particularly serotonin, norepinephrine, and dopamine. Most antidepressants relieve depression by affecting these neurotransmitters. Antidepressants are also commonly prescribed to treat insomnia, long-term pain, and anxiety disorders. Antidepressants fall under the categories of SSRIs, SNRIs, atypical antidepressants, and tricyclic and tetracyclic antidepressants. Each type of antidepressant affects the neurotransmitters in a slightly different way. Although some people say they've felt a lot better after only a few days, it usually takes several weeks before feeling relief of those depressive symptoms. The medications with asterisks here are often prescribed for other conditions such as sleep or neuropathic pain or appetite. So that's just why I have them start on there. Because different types of antidepressants work in different ways, they also have varying side effects. On this slide, you can see some of the variety of side effects that can occur, but we're going to go through the medications, each class, to give you a better idea of what's what. So let's start with selective serotonin reuptake inhibitors. SSRIs increase the availability of the neurotransmitter serotonin in your brain and your body. Having more serotonin helps you feel happier and have a sense of well-being. SSRIs are safe and relieve depression for most people. However, they can cause sexual side effects, which is the #1 reason people stop taking them. And you can see SSRIs listed here. And you've probably heard of these. I think Prozac was the big one that was so popular when SSRIs first, were discovered. And then a lot of folks take Celexa or Lexapro. See a lot of Zoloft and Paxil. I don't see Luvox used very much anymore, but I have seen some clients who are on Luvox, but not quite as often as the other ones. So serotonin norepinephrine reuptake inhibitors, or SNRIs, increase both serotonin and norepinephrine in the brain and the body. The availability of norepinephrine helps decrease anxiety and depression. SNRIs include venlafaxine or Effexor, which is known to cause side effects similar to those caused by SSRIs. However, venlafaxine can raise blood pressure, and overdose on venlafaxine is really very dangerous and can be fatal because of the marked rise in blood pressure that it can cause. Desvenlafaxine, or Pristiq, is less likely to cause sexual side effects and other side effects than the venlafaxine. It's a relative, you can tell by the name. But there's really not enough research on Pristiq. It's fairly new, and I don't actually see that one prescribed very often. I'm not even sure if they've come out with the generic yet, so that might be why, because it's pretty pricey. And then the last SNRI is Cymbalta or duloxetine. And Cymbalta is often prescribed to help relieve physical pain in addition to depression. Common side effects are dry mouth and constipation. And if you're a heavy drinker or you have certain liver or kidney problems, you shouldn't take duloxetine because it's processed through the liver and partially by the kidneys as well. So that's a contraindication. But for folks that have like neuropathic pain in addition to depression, Cymbalta can be a great way to treat both issues with one medication. So moving on to atypical antidepressants. These medications are called atypical because they don't fit neatly into the other categories. Generally, atypical antidepressants cause fewer sexual side effects than other antidepressants do. And they include bupropion or Wellbutrin, which is a reuptake inhibitor of norepinephrine and dopamine. It has the fewest sexual side effects of all antidepressants. It also suppresses the appetite, and it can help people quit smoking. So you might see that prescribed for individuals just simply for those, as an appetite suppressant or smoking cessation drug. People with seizure disorders shouldn't take bupropion though, because it does lower the seizure threshold. And for people with eating disorders, bupropion is not appropriate because you certainly don't want to suppress their appetite for folks that are having trouble eating enough anyways. Trazodone is another atypical antidepressant. At really pretty high doses, it's a fairly mild antidepressant, but it's often also prescribed as a sleep aid at a low dose, like 50 milligrams maybe, because it can be really sedating. So usually individuals who are prescribed trazodone are told to take trazodone at bedtime because it will make them tired. Trazodone doesn't increase anxiety or insomnia or sexual symptoms, which is often associated with SSRIs. And you imagine that, SSRIs are increasing that serotonin. They're giving you that uplifting, energizing kind of feeling. Whereas trazodone, on the other hand, it doesn't do that. It's more relaxing. It's going to help the person sleep, help them stay calmer. And then mirtazapine or Remeron, like trazodone, should be taken at bedtime because it's pretty sedating. The opposite of bupropion, Remeron, actually increases the appetite. So this is really often prescribed for individuals who struggle to keep weight on. But it can increase the lipid levels and cholesterol levels. So individuals who are taking Remeron should be having their labs monitored at least annually, looking at the cholesterol and lipids. But, you know, you picture like somebody who maybe is really depressed, and when they're depressed, they eat a lot. Maybe they're a snacker, or they just want to sit and eat. And somebody like that, Wellbutrin might be a great choice, right? It's going to help with their depression, and it's going to suppress their appetite a little. And then you've got other folks who, when they're depressed, they don't eat. They totally lose their appetite. And so that's when mirtazapine or Remeron might be a good choice. So, and these are the things that doctors are looking at when they're prescribing these medications, is those specific symptoms and what medication is going to work best for those. So tricyclic and tetracyclic antidepressants are older antidepressants, and they're usually not a first choice treatment for depression because they have a lot of side effects. Very much the anticholinergic side effects we talked about with antipsychotics: dry mouth, constipation, difficulty urinating, sedation, weight gain, and sexual side effects. In some cases, a low dose of a cyclic antidepressant is added to another antidepressant, like an SSRI, to increase the antidepressant effect. But, you know, you just don't see them used all that often. Nortriptyline and amitriptyline, those are sometimes used for pain. So you might have a client who is prescribed those for pain as opposed to as an antidepressant. And doxepin is interesting because that medication is 5 times stronger than Benadryl as an antihistamine. And it's a lot of times just prescribed to help people sleep because it makes them tired. It is important to note, though, with these older antidepressants, that overdosing on them can be very, very dangerous, if not deadly. They're not usually given to older adults or people who have chronic low blood pressure or certain heart problems, because they can interact with those conditions. And then, not on this slide, and actually I didn't include in the presentation at all, is a class that's called monoamine oxidase inhibitors, MAOIs. You may have heard of these, but I didn't actually include them because they're really a last resort, and most people, most doctors are not prescribing those medications anymore. They can cause really potentially dangerous side effects. And they also can cause fatal high blood pressure when combined with certain foods and beverages and certain other medications. So you're not going to probably see those ordered, but that is the last class of antidepressants. But like I said, I didn't put it on the slide because I figure you're probably never going to see it. Important to keep in mind, people are unique individuals. And each person has a unique body and a unique brain. Antidepressants are also unique in the way that they work and the effects that they have. So a medication that worked for one person might not work for someone else. It's really important to work with the doctor to find the right antidepressant for that individual. And sometimes it is trial and error, and people will go through more than one trying to find what works. Okay, so on to our last class, and we're going to talk about mood stabilizers. So Simply defined, mood stabilizers are medicines that are used in treating mood disorders like bipolar disorder and depression. Bipolar disorder is characterized by mood swings in which the individual cycles between mania and depression. The symptoms fluctuate from euphoria and limitless energy in the manic phase to the depths of depression with low energy, guilt, sadness, decreased concentration, lack of appetite, and sleep disturbances in the depressive phase. And because of the wide range of symptoms from mania to depression, bipolar disorder is often called manic depression. But also, you'll see down there on the list number 4 is the schizoaffective disorder. And just in case you weren't sure what that means, schizoaffective disorder is basically if you took schizophrenia and bipolar disorder and combined them. So schizoaffective disorder is someone who has psychosis and is typically treated with antipsychotic medications for the psychosis. But the affective piece, that's the bipolar part. So they are having psychosis, but they're also having those high highs and low lows in their mood. And so they would generally be on a mood stabilizer in addition to an antipsychotic to help control those symptoms. And other disorders listed here, cyclothymic, which is a cycling kind of mood disorder, not as severe as bipolar disorder. Dysthymic is very similar to depression, just not happy, not able to find that wellness, and not so much cycling, but just more of a mood issue. And then intermittent explosive disorder is on here because mood stabilizers really help keep those individuals right in the middle where they're not blowing up as easily. They can be very effective for that. So following the acute episode of bipolar disorder or schizoaffective disorder, mood stabilizers are used in maintenance therapy to prevent that cyclical relapse of abnormal mood elevation and depression. The goals of that treatment with a mood stabilizer are 1, to reduce residual symptoms, 2, to prevent manic or depressive relapse, 3, to reduce the frequency of the cycle from mania to depression, 4, to improve functioning, and 5, to reduce the risk of suicide. So, making that cycle longer, you want it, people are going to cycle if they've got bipolar, and the farther apart you can have those cycles be, the better, and the less severe, the better, and the safer for the individual. So here are the categories of mood stabilizers. They are anticonvulsants, minerals or lithium, and also antipsychotics. Some of those are used as mood stabilizers as well. So first, I'd like to talk about lithium. Lithium was one of the first mood stabilizers used in the treatment of bipolar disorder. It comes in 2 forms, lithium carbonate and lithium citrate. Lithium carbonate is available in immediate release, meaning when they take it, the therapeutic level goes up really quickly and also comes down fairly quickly. But it's also available in controlled release. So that's going to give you kind of a longer therapeutic blood level, and usually longer amount of time can go between doses. Lithium citrate is a liquid medication, which is very helpful, for individuals who can't take pills. Lithium was the most important mood stabilizer for many years, but Depakote, an anticonvulsant, has surpassed lithium for the treatment of bipolar disorder. And the reason is that lithium has many troublesome side effects, including nausea, diarrhea, weight gain, and mental sluggishness. But also, there's a risk of toxicity with lithium when there's too much lithium in the blood. So we've divided this into two different types of lithium toxicity because the symptoms of toxicity vary a little bit between. If a person ingests too much lithium at one time, so they take extra doses or they, overdose and take a whole bunch at once, then the symptoms here on the left, that's the things that you're going to see going on with that person. They're going to be dizzy, they're going to be nauseated, have stomach pain, vomiting, slurred speech and muscle twitches, tremors. They could have seizures or go into a coma. However, if somebody is on a lithium dose that is just a little too much for them over a long period of time, and that lithium builds up in their system, they're probably not going to have the GI symptoms from taking too much at one time. The symptoms may come on slowly and be a little more subtle, but that's when you're going to see more of the neurological, like tremors, slurred speech, altered mentation, memory problems. On lab work, they might have trouble keeping salts in their body, low sodium, low potassium. They may have increased psychosis or go into kidney failure. And it's not uncommon for individuals who have been treated with lithium for years and years to have kidney damage from taking the lithium for so long, or at some point being on too high of a dose. So that's kind of the difference in the types of toxicity. But anytime a client who's taking lithium has new onset of these kinds of symptoms, they need to be assessed for lithium toxicity. It's really important to, get them into an ER where they can check their lithium level and make sure that it's not too high. And normally their psychiatric provider, or it may be their primary care if that's who's prescribing it, although not usually, they should be monitoring their lithium blood levels every 6 months at least, just to make sure that it's in the safe range. So if you have clients that are on lithium, please ensure that they're having their lab work done regularly so that they could be monitored for that. Okay, so back to this slide. Now we're going to talk about anticonvulsant medications. Increasingly, anticonvulsants are used as mood stabilizers to treat mania in bipolar disorder. Lamictal and Depakote are used to treat bipolar depression also. Doctors discovered this use for the drugs when they noted improvements in the mood stability among people with epilepsy. At first, anticonvulsants were prescribed only for people who didn't respond to lithium. However, now they're often prescribed alone or sometimes in conjunction with lithium or with an antipsychotic drug to control mania. Anticonvulsants work by calming hyperactivity in the brain in various ways, and for this reason, some of these drugs are used to treat epilepsy, prevent migraines, and treat other brain disorders. They're often prescribed for people who have rapid cycling that would be like 4 or more episodes of mania and depression in a year. And you can see the list here of the anticonvulsants that are commonly used for bipolar disorder. And it's pretty much all the anticonvulsants, right? I don't see Vimpat on there, but you know, a lot of the time we see Depakote. If people can't tolerate Depakote, then, you know, we might see the Lamictal or Trileptal. Topamax, not so often, but sometimes. Neurontin is not super, you know, powerful as a mood stabilizer, but, you know, if they can't tolerate some of these other ones, then that might be tried. But, you know, you've probably had clients who took some of these medications, whether it was as a mood stabilizer or for epilepsy, which is one of the eligible diagnoses to be a regional center client. Some anticonvulsants can cause liver or kidney damage or decrease the amount of platelets in the blood. And so individuals should have lab work drawn every 6 months if they're taking Tegretol, Dilantin, Depakote, and of course, if they're taking lithium as well. So again, making sure that they're getting the lab work done when it's ordered, and you know, that hopefully the doctor is ordering them every 6 months just to keep an eye on those levels. It's really important. Each anticonvulsant can have slightly different side effects, but these are the common side effects of anticonvulsant medications. They do decrease the activity in the nervous system. So, you know, drowsiness, fatigue, maybe dizziness. And some of these will resolve after they've been on it for a few weeks and their body's gotten used to it. But do watch for, you know, new tremor. Rash is something that is common in Lamictal or lamotrigine. And that rash is a very bad thing. So if somebody is started on lamotrigine or Lamictal as a new medication and they develop a rash, you want to make sure to let the doctor know right away, and they'll probably change them to a different medication. Weight gain is can always be an issue with medications that are, you know, more sedating, and you know, some people do complain of nausea. But like I said, most of these lessen with time. Long-term effects can vary, but in general, with anticonvulsants, pregnant women shouldn't take them without consulting with their doctor because some do carry a risk of birth defects. And many anticonvulsants can cause problems with the liver over the long term. So along with those other labs, monitoring liver function tests probably on an annual basis would be warranted. Also, anticonvulsants can interact with other drugs, even aspirin, and cause serious problems. So it's really important to be sure that all of the clients' doctors know what drugs, herbs, or supplements they're taking so that combinations aren't inadvertently prescribed. It's, you know, it's important, especially if they're seeing a psychiatrist and a primary care, that the psychiatrist knows anything, you know, that they're taking that's prescribed by the primary care, and the primary care knows what they're taking that was prescribed by psychiatry, not just so that they're not like duplicating orders, but so that they can check for any contraindications of the medications that they're on. And then just real quick, because we already talked about antipsychotics, I just want to mention again that second generation antipsychotics can be used as mood stabilizers. And they work really quickly in the treatment of bipolar disorder, especially in older adults. They have all been found to be an effective treatment for manic episodes, which manic episodes generally involve quite a bit of psychosis. And some studies show that a combination of an antipsychotic and a mood stabilizer is more effective than a mood stabilizer alone. So since we have a little more time, so I do want to just talk real quick about gradual dose reductions. I think it's really important that that you know that there are regulations for individuals living in licensed facilities that call for a reduction in the amount of psychiatric or psychotropic medications that are used to control challenging behaviors. However, these regulations are not intended for medications used to treat psychiatric disorders. And reducing or discontinuing medications that are effectively treating a psychiatric condition can have really devastating effects. For example, schizophrenia and schizoaffective disorders are progressive diseases. And what that means is from the time the person's diagnosed until the end of their life, that disorder is going to continuously get worse. Each time that a person has a psychotic relapse of schizophrenia or schizoaffective, they do not return to the same baseline. So preventing a relapse is the goal to maintaining function for as long as possible for those individuals. Reducing medications because a licensing person says that you should is really unfair to the client in that you put them at risk for having a psychotic episode and relapse, and essentially they aren't going to return to their same baseline they were at before. The more relapses an individual has over their life, the worse their general functioning is going to be. So that's one reason, but also reducing medications that are effectively controlling depressive symptoms can lead to debility or suicidal ideation or successful suicide. So if someone has a diagnosis of depression or major depressive disorder, and they're on an antidepressant, and that antidepressant has them stable, it's not appropriate to decrease the medication or change the medication or discontinue it simply because someone from licensing says that you should. And we'll talk more about that too. Reducing medications that are effectively controlling manic symptoms can lead to behaviors that put others or themselves in grave danger. People who are manic do really wild things. They can be very aggressive and very psychotic. They can do, run out in traffic or, climb things that are dangerous. Or I can't even tell you how all of the things that people have done when they're manic, but they're all very dangerous and not only to themselves but to other people as well. And again, if they are on medication that is effectively keeping them from being manic, it is not okay to reduce or discontinue that medication based on the regulations for gradual dose reductions, which are really meant for medications that are used to sedate and control people who have behavior problems. So what do you do to protect yourself and the client? You want to keep documentation from the client's prescriber that supports continued use of psychotropic medications for their psychiatric condition. And you should have them, and hopefully if you're working in a facility, you have a form that you've already, where they can just fill in the blanks, right? but it needs to have what their psychiatric diagnosis is. It can't just say aggression, or it shouldn't just say anxiety, right? It should be a psychiatric diagnosis. I mean, generalized anxiety disorders, anxiety, but it should be a DSM-5 diagnosis for a psychiatric condition. And the medication that they're stabilized on, it doesn't necessarily have to state the dose, but it should list the medications that they're stable on. And somewhere in there should be a statement that the client is at high risk of destabilization, hospitalization, or death if the medication were to be reduced or discontinued. Now, granted, if the person is on, say the person has schizoaffective disorder, just as an example, and they're taking an antipsychotic medication for their psychotic symptoms, and they're taking a mood stabilizer for their manic and depressive cycling, and they're also taking a benzodiazepine for anxiety. Out of those 3 medications, the only medication that I would think would be reasonable to consider doing a reduction on would be the benzodiazepine, because that's just really calming them down. It's not controlling their psychosis. It's not controlling their mania and depression. So obviously if someone's on multiple medications, maybe considering one of those for a gradual dose reduction, whichever one is controlling that, like a specific behavior, such as agitation or anxiety. But I just want to emphasize that the regulations for gradual dose reductions is not meant for people who have a psychiatric illness, who are stable on their meds. And it's really, really, really hard to see clients relapse and get very sick, and oftentimes, end up losing their housing or in a psychiatric hospital, and sometimes often not returning back to their baseline because of that trial. So I just wanted to throw that in there because I do think it's really important. Okay, so I'm going to go ahead and turn on my camera and stop sharing my screen. I'm going to stop recording.